Did you know that menopause is just one day in your life? Hi, my name is Anita Kaiser. I'm a scientific associate at Kite Research Institute, University Health Network, and a person living with a spinal cord injury since 1996. I also transitioned through menopause during the COVID-19 pandemic. Joining me is my colleague, Margaret Conquest.
Hi, everybody. I'm a sexual health educator and advocate. I'm gleefully retired, and I'm living with spinal cord injury since 1991. Oh, and I am also living my best life 3 years post-menopause. This is episode 1 of the podcast series, Menopause and SCI in a Hot Flash, where we will provide a general overview about menopause, talk about some of the myths and misconceptions, and how to get trustworthy information on this topic.
Joining us is our guest, Dr. Kathy Craven, a senior scientist at Kite Research Institute, medical director of the Spinal Cord Rehab Program at Toronto Rehab, and a professor at the University of Toronto. Welcome to the show, Dr. Craven.
Thanks for having me, Anita and Margaret.
So the main purpose of this podcast is really about menopause awareness and normalizing menopause.
I absolutely agree. We need to make space for conversations about menopause, and we need to make it a normal discourse, just like conversations about puberty, pregnancy, and childbirth. This season of life is no different, and women should feel comfortable and know that it's completely fine to talk about their experience.
I agree, Margaret. Menopause is really both a biological and a psychological transition for many women. It occurs when their period stops and our reproductive years end. I'm sure you're aware that menopause is accompanied by hormonal, cognitive, emotional, and physical changes that can significantly impact a woman's mental health and well-being. While it's a natural part of aging, the experience can vary widely, with a wide range of symptoms being normal, with some women really sailing through the experience with minimal symptoms, and others facing significant drama and sustained challenges to counteract the impacts of menopause.
Before we really dive into this topic, I think we need to establish an understanding of some of the terminology we'll be using throughout the podcast series. Dr. Craven, you talked about and defined menopause, but is perimenopause the same or is it different?
Perimenopause is quite different. It's the transition period before the onset of menopause, and it can be associated with really a wide range of physical and emotional symptoms that are usually driven by fluctuations in hormone levels. Common symptoms include irregular periods, hot flashes, night sweats, vaginal dryness, sleep disturbances, and mood changes. Other potential symptoms include urinary issues, changes in libido, and cognitive changes like brain fog.
So then can you also clarify the language that we use throughout this series around sex and gender in the context of menopause?
Okay, I'll try to do my best to clarify some confusing terms. Sex generally refers to our biologic traits, things like chromosomes, hormones, and reproductive organs that are typically characterized as male or female. So our biologic sex is essentially the reproductive organs that you are born with. On the other hand, the term gender encompasses the social and cultural aspects of being a woman or of another gender and includes a number of roles, behaviors, expressions, and identities. If I'm to clarify, Margaret, sex is often really talking about biological and innate traits, while gender is really a social construct that can be fluid and vary across cultures and time. Throughout this podcast, we use the term woman to generally refer to people who have female traits and female reproductive organs.
So how about we start breaking down some of the common myths and misconceptions around menopause? I can say that I originally thought that menopause was a short phase all women went through, and once you crossed over, you were free and clear.
That hasn't been my experience, Anita. Menopause is not just a single moment in time. It's not temporary, reversible, or a death sentence. or the end of vitality, although some women see it as freedom and the first time in their lives that they haven't had to struggle with their periods. Some women think that if their periods disappear following a surgical intervention, such as endometrial ablation, where they scrape out the lining of the uterus, somebody has a hysterectomy or an IUD as a form of contraception, they will often say, I didn't go through menopause because they didn't experience the full physiologic, emotional, and cognitive impacts of menopause. If we look across cultures, menopause is experienced and seen differently across a variety of cultures. In some regions, transitioning from perimenopause to menopause is seen as an important rite of passage and infers some wisdom, while in other cultures it's seen as a time of accelerated aging in contrast.
So you just talked a little bit about some of the positive sides of menopause, one of them being becoming wiser. And I certainly feel a little bit more at peace with who I am. In addition to that, though, something way more practical that I can think of is no more periods. And I remember going through perimenopause and having some heavy irregular periods and just praying and hoping and wondering when I'm buying products if this would be the last time I'd have to buy the damn things.
Certainly, abandoning tampons and pads is liberating for women, but through the process of perimenopause and menopause, developing greater insight into oneself and being less influenced by your biologic rhythms and social norms can really be freeing.
So, what do we know about menopause considerations for people with spinal cord injury? I found so many of my symptoms were similar to other SCI complications that I deal with. And it wasn't until months later when I would look back and then I'd realize that some of those things I experienced were likely related to menopause.
Anita, I think you've hit on the crux of the issue. It can be really hard to separate out some very subtle symptoms related to menopause or specific health complications. Two specific examples might be changes in vaginal bleeding. Sometimes women with SCI have just become accustomed to bleeding during their bowel routine, and they don't get too excited by subtle changes that may be from vaginal bleeding as opposed to perirectal bleeding following the bowel routine. Some very subtle cognitive or emotional symptoms can sometimes be hard to separate out, particularly if people have a seasonal affective disorder. They may have trouble separating out the symptoms of seasonal affective disorder versus some of the emotional consequences of menopause. And of course, our all favorite night sweats can be really difficult to sort out the etiology or cause in women with spinal cord injury. And you really need to speak up and share concerns about your health or changes in you and your body with your care team so that we can do some joint problem solving. Particularly night sweats can be really challenging to separate out what might be early syrinx formation, developing a chronic and serious infection, or just simply good old menopause related hot flashes.
I know that aside from just the experience of the symptoms, one of my biggest challenges was trying to access and then navigate the healthcare system, particularly during perimenopause. There were times when I felt dismissed and it sort of delayed getting my symptoms addressed. It got pretty tiring, actually. What advice might you have for women as they try to navigate the system and prepare for appointments?
I guess that an important starting place would be to think about looking for someone who is a women's health provider, who looks at women individually in a more global way, looking at your physical, mental, social, and spiritual well-being. And for many women with disability or living with spinal cord injury have experienced some form of trauma. And so it's really important to make sure that wherever you're getting care, that you feel safe and that you can trust your healthcare providers with the concerns that you are raising. This can be particularly challenging for people who have survived domestic violence, workplace hazards, or have some challenging life circumstances, such as living in a public shelter. I really like it when women try to prepare for their appointments and try to bring information to help the healthcare provider understand how your symptoms are impacting you on a day-to-day basis. Some symptoms which can be subtle, you can understand them more if you can understand their impact on a person's day-to-day function. It's really important that when you seek care from a women's health provider, that if you have had a traumatic experience in the past, that you at least try to disclose that to the provider so that they can actively avoid re-traumatizing you and really support a safe interchange of information during a visit.
Yeah, and I think along those lines, finding trustworthy and reliable information is so important. But there is a fair bit of information on menopause if you search the web, but very little that's specific to spinal cord injury. And there are many suggestions for managing symptoms, but how do we know what is accurate information and safe?
Totally. I felt like I was largely left to search out information on menopause generally, and then to try and mesh that with my own experience and knowledge of spinal cord injury. And at times, I often felt desperate in trying to manage my symptoms, and I was often and almost willing to try anything marketed to women in perimenopause. And I can say without shame and honestly that it did lead me to seek out a private clinic for a while, and they definitely didn't have my best interests in mind. So it's a tough one to navigate.
I agree. Menopause and perimenopause are a really challenging time. What's also confusing for both healthcare providers and women living with spinal cord injury is there's not a lot of evidence out there about what is the best or most appropriate care for women living with spinal cord injury. Usually in the field of medicine, we rely on gold standard research that comes from clinical trials where individuals are randomized into one intervention over another. And we have evidence from large case series of people, groups of 300 or more that are used to drive our health policies and clinical practice guidelines.
You mentioned clinical practice guidelines. Can you describe for our listeners what they are and how they're developed? And finally, how people should interpret and use them in real life?
When we talk about trustworthy information, a lot of people talk about clinical practice guidelines as being the end all and be all, but clinical practice guidelines are really just tips to help clinicians and patients make informed decisions. And guidelines usually aim to provide a minimum standard of care that will improve a patient's health and quality of life, but also reduce unwarranted investigations or costs to the health system. And I think it's important for patients, and particularly women living with spinal cord injury, to know that clinical practice guidelines are really not hard and fast rules, but they're tools there to support clinicians who aren't sure what to do. One great tool that I found to be quite useful is the Menopause Symptom Tracker. This is a free resource you can download and track your own symptoms, and you can bring this to share with your doctor and have a conversation about getting the help you need.
The symptom tracking tool is actually quite good. I've used it myself. You need to go to the Menopause Foundation of Canada, and it will prompt you to give your information to them. And then you'll receive a link to download the tracking tool, and you can go from there. So then, can you describe to our listeners what clinical practice guidelines are and how people should be interpreting and using them in real life?
Great question, Margaret. I will try my best to simplify some complex concepts. Clinical practice guidelines are only as good as the data that are put into them. In fields like cardiology, where there's lots of available evidence, a large number of people in the population, we can systematically merge data from multiple investigators to come up with informed decisions about appropriate care in different scenarios. In rare conditions like spinal cord injury, where only 1 in 4 people with spinal cord injury are women, it's challenging to put together clinical practice guidelines in some aspects of care because there's not a lot of high quality evidence. And when there's a lack of high quality evidence, we in the field experience what we call equipoise, where people don't know what to do. That leads to a lot of myths about health conditions being developed and a lot of misinformation being shared. In preparation for this podcast, we did a systematic search of the available spinal cord injury literature and found a lot of survey data that's been used to inform the design and content of this podcast. But because of the lack of high quality evidence or studies using large numbers of people with robust outcomes, we have opted to approach colleagues in the field with relevant content expertise to try to round out the content of this podcast in terms of making sure that it is relevant and includes data from trustworthy sources.
So to end things off, what key message would you like to leave our listeners with?
Sharing your thoughts, opinions, or concerns during a healthcare encounter can be a challenging situation, but communicating honestly can lead to a better partnership with your healthcare provider and bring your voice into the care plan. So talk it up. Start by speaking up a little and work your way up to the more challenging and difficult conversations.
So before we go, here's a sneak peek into some of the topics that we'll be covering in future episodes. We'll be looking at skin and vaginal health, vasomotor symptoms or hot flashes, osteoporosis, cardiometabolic health, mood, cognition and sleep, and breast and ovarian cancer, not necessarily in that order.
It is important for the listener to have some context for this podcast. Although there's a lot published about menopause and spinal cord injury, totaling over 3,600 articles, there's only a small number of studies evaluating interventions for menopause among female participants living with spinal cord injury. After conducting a scoping review, we identified one randomized control trial evaluating an education intervention, 3 prospective or longitudinal studies, 5 surveys, and 11 narrative reviews, and a handful of case control and case series. All this is to say that the available evidence about menopause and spinal cord injury comes from surveys of patients regarding symptoms, their frequency and severity, and narrative reviews from healthcare providers. As a result, the content of this podcast series is derived from the limited available evidence and the content expertise of the invited guests. I know you think this is unacceptable, and I agree that yes, we can and should do better as a field. A key driver for changing women's health is empowering women like you to talk about their experiences and to seek assistance as an important first step. Unlike other aspects of SCI care, a provider well known to you who is trusted with expertise in women's health is likely your best bet until we grow the evidence base. We hope you will see this podcast as an opportunity to track and report your symptoms to a trusted care provider.
If you found today's talk interesting, check out our action planning tool on the website at www.scifragments.ca and feel free to send us your feedback using the survey provided on the website. In the next episode, we'll learn about the effects of vasomotor symptoms like hot flashes. Special thanks to the Paralyzed Veterans of America Education Foundation grant for funding the podcast series Menopause and SCI in a Hot Flash. This podcast series is hosted by Dr. Anita Kaiser and Margaret Conquest. The executive producer is Dr. Kathy Craven, and co-producers are Dr. Anita Kaiser and Dr. Hope Jervis-Rademeyer. The production team includes Dr. Kathy Craven, Dr. Hope Jervis-Rademeyer, Dr. Anita Kaiser, Margaret Conquest, Dr. Masai Miyatani, and Dr. Lindsay Blanco. Sound design is by Dr. Hope Jervis-Rademeyer. The project team is affiliated with the University Health Network in Toronto. We appreciate the feedback from people with lived experience who acted as podcast reviewers and helped us to refine the podcast content over time.